Okay, well, welcome everyone. My name is Anthony Muhll. I'm a licensed acupuncturist and doctor of acupuncture and oriental medicine. The subject of today's class is essential orthopedic acupuncture techniques and modalities. So I want to thank you all for being here and welcome you. This is my area of specialization is orthopedic acupuncture. It's been pretty much my sole and exclusive focus of practice since I graduated from the Five Branches University of Traditional Chinese Medicine in Santa Cruz, California in 2001, and have been in continuous practice since that time in California and now in Charlottesville, Virginia. And I'm going to begin by just talking a little bit about where this material comes from. I focused on this area of acupuncture because it basically coming out of my own personal experience as a serious but clumsy amateur soccer, basketball, and soccer and basketball player and cyclist, and got a lot of injuries in my 20s and found that the combination of Tai Chi and acupuncture and Tui Na manual therapies were very effective, more effective than conventional physical therapy in addressing my issues. And after graduating and getting licensed in 2003, I founded a clinic in Santa Cruz, California, and went on to get a board certification in acupuncture orthopedics through a unfortunately now defunct organization, the National Board of Acupuncture Orthopedics in the U.S. It was a rigorous 300-hour course on top of my master's degree training that I completed in 2006. I also did a specialty program with Dr. Alon Marcus, now retired, in joint needling, and that's one of the techniques I'm going to be spending the most time with today. And I also decided in 2017 to go through the highest quality, most rigorous of the myofascial trigger point or dry needling programs taught by physical therapists, myopain seminars. They actually teach all over the world, but I now have completed their training as well. And I earned my doctorate with a specialty track in orthopedics and pain management through the Academy of Chinese Culture and Health Sciences in 2020. What I want to begin here by talking about is just clarifying, at least my clarification of some terminology which often gets mixed up or a little bit confused in our profession. And one of the two main orthopedic techniques that I want to spend the most time on both depend in part upon palpation skills and finding tender trigger points that reproduce the patient's typical symptoms. And in classical Chinese medicine, these are referred to as ashur points, which is often mistranslated as tender, but really means something more like eureka, I found it, aha. I found the place that when pressed on or needled into reproduces the patient's typical symptom pattern in a mild, tolerable, and therapeutic form. If you squeeze large intestine 4 or liver 3 on just about every patient, they're going to report tenderness, but that's not what I'm looking for. I'm looking for, I got my needle into the spot where they go, oh, yeah, that's the pain I've been feeling. You got it. Okay. That is a classical technique from Chinese medicine with a lot of overlap with the contemporary practice of myofascial trigger point needling. Trigger points are tender nodes in a taut fibrous band, often described by the patient as a knot in the muscle. But it's not that the fibers are truly knotted around each other, but they are stuck in a shortened and contracted position that sends out pain signals and interferes with blood flow. And there are typical preferred pain patterns that go along with individual muscles when they have myofascial trigger points in them. Now, you might have heard the term motor zone. This is another contemporary neuromuscular understanding of how acupuncture can work. Motor zones are the location where the primary motor nerve that makes a muscle contract enters that muscle belly and are sites of increased electrical activity, but they can become dysfunctional and the muscle can be either tight and hypertonic or flaccid and loose and relaxed and not firing properly. And these are dysfunctional motor zones are a common site for trigger point formation. And there's a lot of overlap with classical acupuncture points with all of these. Many of our classical acupuncture points do turn out to be ashur, eureka points, or places where myofascial trigger points form, or motor zones where the main motor neuron enters the muscle belly. So these are zones of interest for orthopedics. In terms of the organization of the human body, this translation here is sort of my summary of a couple of different authors that I want to credit, Donald Kendall and Pony Chang, both of whom have engaged in very, very careful retranslation of some of our Chinese classics and seeing much more clear correlation between the terminology of classical Chinese medicine and contemporary orthopedics. So our greatest area of concern here with orthopedics, meaning, bone and joint really are the gu, the bone or the skeleton. Not much we can typically do about bones themselves with acupuncture modalities, but the joints, the myofascial tracts, these longitudinal pathways of muscles joined by tendons and ligaments and aponeuroses and other forms of connective tissue, are described in the Neijing quite clearly as the Jingjin, sometimes translated as sinew meridians, which is sinew being kind of an archaic term in the English language. Myofascial is probably a much better contemporary term. Myofascial tracts is what I prefer to call them rather than sinew meridians. And those are the Jingjin is really what we're going to be able to work with most with needles and with manual therapies in orthopedics. The Jingluo are where our classical acupuncture locations are found, and Jingluo, often translated as meridians. Translation that I prefer would be our deep vascular lymphatic vessels and the spinal cord and sensory motor nerve distributions that are embedded in musculoskeletal tissues. So one of the misconceptions I want to clear up is somehow is that the Jingluo are primary and deeper and the Jingjin are superficial and of less interest. That's not stated anywhere in Chinese classics. That's a modern misconception or mistranslation. And in fact, what is described in the Chinese classics is something much more akin to our contemporary understanding of the organization of the human body, in which vascular lymphatic vessels and neurovascular bundles are embedded within muscular tissue. And the muscular tissue is both deep, going all the way to the bone, and superficial, going to near the skin. So those are our three areas of greatest concern: the gu, the bone skeleton, the Jingjin, most of all, and the Jingluo. Okay. So I want to put in context both the standard training that we receive in the West for treating pain and neuromusculoskeletal problems and orthopedic injuries, and also some of the specialty techniques where I'm going to be spending the bulk of my time today. So in this overview, the neural and psychogenic aspects of pain, meaning, say, stress-related pain, neuropathic pain, where the nerves themselves are pain generators and not just transmitting pain information, but are themselves damaged, things like carpal tunnel syndrome or sciatica, and also functional contributions to disability. There may not be anything structurally wrong, but there's a functional disharmony, a functional imbalance, a dysfunctional pattern that's become established. So the point that I want to make here is that there's nothing that I'm going to say today that says, oh, stop using your classical acupuncture locations, liver 3 and large intestine 4 and large intestine 15 and gallbladder 30 and so on. These are all very, very useful for treating these aspects, neural and psychogenic aspects of pain and functional contributions to disability. And in fact, I'm going to quote Pony Chang here, that one way to understand the Chinese classics that describe acupuncture meridians and points is a map of the peripheral nervous system. So starting with our distal limb, our Jingwell, Ying Spring, Shoe Stream, and Jing River points, these are all found at clinically significant branching locations of the peripheral sensory or motor nerves. When we move to the proximal limb, the thighs or the upper arms, and our Hesi points that are around the limb, the major limb joints in between proximal and distal, this is where we find our locations, our acupuncture locations that are we can use to influence mixed sensory motor nerves, where the nerve is not yet split or differentiated into sensory or motor. Here they're mixed sensory and motor bundled together still. Moving on up to this paraspinal region, to our Huatou Jiaji line and our inner bladder lines. This is where we can affect the spinal nerve roots that exit the spinal cord through through the neural foramen of the spine and form spinal nerve roots. The spinal cord itself, we can influence in the same locations along the Huato-Jiaji and urinary bladder line. Then we have this the spinal cord. We're now transitioning, of course, to the central nervous system, and the other part of the central nervous system, the brain, we can influence through scalp, the motor and sensory regions of the scalp. And then we have the autonomic nervous system, the paraspinal ganglia that regulate sympathetic and parasympathetic imbalances and are supplied by the vagus nerve. The vagus nerve also goes to the earlobe, so we can use both auricular locations and paraspinal locations to affect the autonomic nervous system. And any and all of these areas of the nervous system can be significantly involved in pain. So here, just to review, on the left-hand column, we have the type of neural tissue involved, starting with peripheral sensory and motor nerves at the extremities and progressing through the central nervous system, the spinal cord and brain, and the autonomic nervous system. Here are the candidate body regions for needling those types of neural tissues, beginning with the transporting points in the distal limb, Jingwell, Yingspring, Shoestream, and Jing River, the proximal limb being the Hesi, our paraspinal locations, the Huato-Jiaji and the inner bladder lines, the scalp, motor, and sensory regions, and then finally the auricular region for influencing the autonomic nervous system. Okay, so everyone's seeing that now? We're all good? Okay.
Yes, thank you.
Okay, great, thank you. Okay, so moving on down, what's missing from that picture is something that I'll spend basically most of the rest of this webinar on, is the effective local treatment for orthopedic and inflammatory aspects or contributions to pain, joint and myofascial dysfunction, structural contributions to disability. And this is something I've learned both through my specialty training and my clinical experience that I think is not fully appreciated, at least in the West, is just how much we can do with needles to affect structure, not just feeling, not just emotions, not just pain, not just sensations, but actually change the physical structure of the human body in a lasting way that reduces not only pain, but improves function and improves physical, capacity. So we can achieve this through needling, specialized needling techniques that are described in the Neijing and have been expanded upon in modern needling, needling of ligaments and joints. Joints can also be treated through Tuina, through joint mobilization and joint reducing subluxations or dislocations, manual therapies for joints and for muscles too. And muscles can be treated through and tendinous structures, myofascial structures. We can needle into trigger points or Ashur points. We can also apply gua sha techniques, scraping with the blunt edge of a tool like a wonton soup spoon is my favorite for that. Orthopedic types of cupping. And so mostly I'll be talking about needling. If we have enough time, I'll spend a little time on orthopedic gua sha and cupping as well. Okay, so by combining this local approach where we're actually changing structure locally and affecting structure locally with what we learn kind of in the basic master's level training in the West, at least, we can have a much more complete, effective, lasting package of approaches to treating orthopedic and neuromuscular skeletal pain and disability. Okay. So I'm going to talk a little bit, this is from my personal experience and study of where needling techniques work best on structure, on the Jingjin, the myofascial tracts. And here you'll see at the top, I've organized myofascial and musculoskeletal tissue types from the most yin, the very avascular hyaline cartilage, almost no self-repair capacity, as close as anything comes to inert tissue in the human body. Cells not dividing and reproducing, not remodeling, no blood flow. It's just like a inert buffer in between bones. And doesn't respond very well to much of anything. But one of the tools we have, needling into that, is into the hyaline cartilage with a needle can actually be therapeutic for it. Can allow blood to flow into that area and promote the release of tissue growth factors and a little bit of tissue repair. Not great, but there's nothing else that does it at all. So it's the tool that we have to help repair the inside of joints, but also other joint structures we can affect by needling directly into them. Fibrocartilaginous structures like menisci or small discs, not the intervertebral discs, but the tiny discs that live in the temporomandibular joint or the facet joints along the spine. The ligaments and capsules and labrums that form joints as well. The ligaments and capsules that kind of form the exterior of the joint, and the labrum like a rubber gasket that holds the humerus and the scapula and the femur and the hip bones. There's bone and periosteum itself, which is really hard to classify in terms of yin or yang. It's kind of mixed because, bones are very structural, but they also are very living tissue that's constantly remodeling. Very dynamic and active, and have a lot of blood flow. And then the further right we go on this little chart here, we have progressively more vascular tissue that self-repairs and remodels very effectively, aponeuroses and fascia, tendons, and finally muscles. And that's why, typically muscle strains and muscle overuse will very often self-repair without any outside intervention unless there are systemic problems or the muscle keeps getting re-injured or there's an underlying joint problem. So the muscles respond very well to trigger point and motor point needling, and all these other connective tissue types respond very well to what we might call proloacupuncture. This is a term I've kind of adopted from the contemporary practice of prolotherapy, shorthand for proliferative therapy. By deliberately needling into and irritating connective tissues in a controlled and therapeutic way, we bring blood flow into the area, provoke reflexes that tighten up the tissue, and cause release of tissue growth factors and collagen fiber formation and tissue repair. Now, functionally, we have electroacupuncture and motor point needling, which is very useful for the neural contributions for pain. Distant acupuncture also working on everything from the psycho-emotional, the neural, and the vascular or lymphatic aspects of pain. And then finally, 7-star, 3-edged, or lancet needling, specialized types of needles that we can use to aspirate congested blood and sometimes lymphatic fluid from an area where it's become really stagnant. So this is my clinical experience. This is suggestive, not definitive. I invite your feedback, but this is how I practice and teach. Okay. So the classical acupuncture texts do tell us that we can treat both locally and distantly. I would like to see a truce between warring groups on social media about whether local or distal is better or, superior, or which is true and authentic. They're both described in classical texts, used in different ways, in different contexts for different patients and different stages of treatment and different conditions, and can be combined quite effectively, more effectively than just picking one or the other. But what I do want to emphasize with here is that this just sort of a complex discussion. I'm just going to summarize. The Neijing describes choosing locations distant to the site of disease, except the sections regarding the Jingjin, the sinew meridians or myofascial tracts, describes only treating locally, treating tender and diseased locations locally as found through inspection and palpation. Okay. Now, I've linked here a personal algorithm that I use for kind of determining to what degree am I going to do distal or local. Most patients end up doing both because most patients have a combination of functional, psycho-emotional, neurologic, and vascular lymphatic problems with local structural, orthopedic, and myofascial problems. Okay. What I'm going to go through fairly quickly here is I want to give you some tips for if you are a distal-only needler and really have an aversion to treating locally. Here are some things that will still make your orthopedic practice a little more effective if you don't already do this stuff. So first of all, we have to identify the most symptomatic and affected Jingluo, or primary meridians, neurovascular bundles, and also the Jingjin or the myofascial tracts. So I will ask the patient when they're at rest, lying on the table, where is their current worst pain? Where along a limb or their spine. And then I also want to know when they move that affected area, say their shoulder or their knee or their ankle or whatever it is, are there other Jingluo or Jingjin that suddenly become symptomatic, particularly those that seem to limit their range of motion in that joint. If they can't move their arm overhead because it hurts too much on their lateral shoulder, that tells me that the Shaoyang Jingjin is likely involved. So often the Jingluo and the Jingjin that are affected are one and the same, but they're not identical in their pathways. And where the pain is felt at rest may differ from where it's felt on movement, and it's all clinically significant. So if we only treat where the patient feels pain when they're at rest, the symptoms are more likely to come back when they get up and start moving off the table. So, so I recommend, having, if I'm treating shoulder pain, for example, and I have needles in the patient's shin, I want them to move their shoulder while they're lying on the table and tell me, where does it hurt and where does it still hurt? And keep addressing those affected Jing-Jin or Jing-Luo. The second thing is to, in terms of, if I'm the example I just gave of treating somebody's shoulder by needling along their shin, I want to examine distally to proximally along the affected and related Jing-Luo and Jing-Jin for any kind of abnormalities. And what I mean by is visible abnormalities, swelling, discoloration, the skin has gone scaly, we're seeing spider nevi, hair loss, something called peau d'orange, which is French for citrus peel, orange peel. And actually, human skin will start to look like citrus peel, particularly along the spine where there's nerve damage. And so that's a very clear, visible signal of trophic changes in the skin over a segment of the spine that's become dysfunctional and where the nerves are damaged. We also want to feel for palpable abnormalities, meaning here significant tenderness. This is what I was saying earlier, not just any tender spot, but that the patient says verbally is tender. What I'm looking for when I palpate for tenderness, I'm actually looking at the patient's face because I want to see those reflexive wincing or grimacing or twitching or jumping on pressure. That tells me that it's highly clinically significant, a kind of tenderness that'll be useful to treat. Okay. Also, other tissue abnormalities that we can feel. The tissue feels rough, gritty, grainy. It's tight. It resists movement compared to the adjacent tissue. It's less mobile when we stroke our fingers across it. Maybe it's boggy, swampy. We can feel edema. There's a temperature change. It's too hot or too cold compared to the adjacent tissue. The skin is really dry. The more of these, the more abnormalities we see, both visibly and palpably, the more likely this is to be a really significant location, even a distant location to needle. Okay. Finally, we need to needle into a depth in tissue to match the target painful location. If the pain is superficial, we can needle superficially. If it's deep and feels like it's inside a joint or at the bone, we need to needle deeper. Needling into the same somatic tissue type increases efficacy. If they have a muscular problem, needling into muscle. If they have a tendinous problem, needling into tendon, ligament, etc. But of course, not arterial or organ. Okay. So, for example, if we're treating a superficial problem with dermatomal pain, where an area of skin that is supplied by sensory nerves is painful, numb, tingly, odd sensations, we can needle fairly superficially along that dermatomal pathway. If instead we're seeing muscle weakness, muscle pain, fasciculations, cramping, abnormal motor activity in the muscle, needling deeper into the muscle, into the myotome, bundles of muscles that are supplied by a particular nerve root that perform a particular motion in the human body. If it's really deep, feeling like it's in the joint, or in the bones themselves, needling into sclerotomes, deep needling into the connective tissues surrounding a joint will be more effective than superficial needling, okay? Even distant. So remember, I'm still talking about distant needling here. So if I want to treat something that's really inside the shoulder joint, it's going to be more helpful to insert deeply to the bone than to keep my distant needle superficial, okay? So then we ask the patient to move the affected area while we manipulate any key needles and report any change in pain severity or location, and observe any changes in active range of motion. Can they get their arm overhead now instead of getting stuck at horizontal? And repeat this process until all previously painful areas can be moved with minimal, 75% or less, reduction in pain or no pain at all. And then encourage the patient to keep moving that target area as long as it's pain-free during the half an hour or so of needle retention. That's really optimal for getting good results. And if they want to rest, that's okay. But it's going to help if they just kind of keep moving the area and then alert me if pain starts to come back. Okay. If it comes back all the way to baseline very quickly, I probably need to either re-stimulate the key needles, or something's wrong and I need to reevaluate altogether, maybe add some more needles. or if it's really severe pain, this distant approach is just probably not going to work very well, and I'll remove the needles and just go local. Okay. So that's about all I have to say about distant needling for orthopedic conditions. Is any questions before we move on to local needling techniques? Okay, so locally, we're going to be treating the Jingjin, the senior meridians. There are 12 of them, first described in the Neijing Ling Shu, chapter 13, as paired with their 12 primary Jingluo. Roughly similar pathways, but not identical. No description of the relationship between the Jingluo and the Jingjin is contained in the Neijing. Some have branches that diverge from the Jingluo. You can see here the foot Taiyang Jingjin. We've got lateral branches around the scapula that don't follow the pathway of the bladder meridian, for example, or going to the side of the jaw, going to the front of the calf. There are areas of knotting or binding that are described, but it's not clear to what exactly, probably to bones. And again, the Neijing Su Wen, chapter 43, places the Jingjin at the very deepest level, just above the bones. They don't have their own shui or points or defined needling locations, but most shui, most classical acupuncture locations are to be found within the Jingjin. And that's really the only description we have in the Chinese classics. It's pretty straightforward, pretty cursory. And only in modern textbooks that start to summarize the Chinese classics do we see any further discussion of the Jingjin. Why, I don't know. I'm not enough of a historical scholar of Chinese classics to have any speculation or theories about that. This slide here, I wanted to use to make the point that the Jingluo and the Jingjin are not identical. So if we needle kidney 9 because we're trying to influence kidney or bladder function through the Jingluo, we don't need to needle super deeply. And if we do needle deeply, we're actually, either way, we're going to pass through, superficial or deep. The Jingjin that kidney 9 is to be found in is actually, it's around where the soleus emerges from underneath the gastrocnemius and starts to blend into the Achilles tendon. So we will actually be needling through what are very clearly Taiyang Jingjin tissues. The superficial posterior compartment of the calf that plantar flexes the ankle, structurally and functionally matches the description in the Neijing of the Taiyang Jingjin, which does not associate it particularly with the bladder or kidney organ, but does form part of the pathway, the myofascial tract, all the way from the plantar fascia on the bottom of the foot, up the back of the calf, the hamstring muscles, the gluteals, the paraspinals, and thoracolumbar fascia, going up the back of the neck, over the gala aponeurosis, and to the tip of the nose. So, and yet kidney 9 seems to be located there, but that doesn't mean that by needling kidney 9, we're going to affect the the kidney Jingjin, unless we do needle very, very deeply, and we get into the deep posterior compartment, passing through the gastroc and soleus into the flexor digitorum longus, the tibialis posterior, this deep compartment wedged between the tibia and the fibula that actually has a different function. These muscles are primarily inverters and toe flexors, ankle inverters and toe flexors, and they are best associated with really all three yin Jingjin. The yin Jingjin, the yin sinew meridians, are difficult to differentiate from one another. It's not really clear that the Shaoyin, Taiyin, and Jueyin have any great differences between them, particularly in the distal limb. They're probably best considered as one large yin Jingjin. And then the other two compartments, while we're here looking at this slide, we have the Yang Ming or stomach Jingjin, the anterior muscles that dorsiflex the ankle and toes, and the Shaoyang, the smallest compartment, the lateral compartment that everts the ankle and the subtalar joint of the foot. Okay. So any questions about that before we keep moving here? Okay. So the classically described Jingjin treatment methodology, is really very simple. It's much less heady than modern TCM, where we have to develop a diagnosis and treatment principles and then a point prescription before we put a needle into anybody. This is much more, in some sense, functioning like a massage therapist with very, very long, slender metallic fingers that will penetrate deeply into tissue. We do, of course, have to identify the symptomatic Jing-Jin, but from there on, it's a very simple process of palpating and inspecting for tissue abnormalities, as I described earlier, treating any abnormalities we find on exam, re-examine to see if the tissue has normalized. It may not show any major changes visually, although sometimes it does, but palpably, typically the tissue will become more uniform in texture, softer, more mobile, less swollen, less tender, less gritty or grainy. Even in the course of a few minutes of needling, we can often feel tissue changes if we're applying our methods effectively. And so we just go round and around this pathway of palpate and look, treat what we find that's abnormal, re-examine, and if there's still some abnormalities, we keep treating until those abnormalities are resolved, or perhaps we run out of time or the patient's limit of tolerance is reached. Okay, so this is just one classical needling method that's applied and described in the Neijing as being useful for muscles and connective tissue and joints longitudinally that form these Jing-Jin pathways within a larger holistic system of medical treatment. And this is really the source, very likely, of our contemporary dry myofascial trigger point and joint needling. It's this ancient description of how to treat the Jing-Jin. Okay, so here too, if there's anything I want you to take away from today, is to trust your fingers and trust your eyes to tell you what are going to be some, to select among the variety of acupuncture modalities and techniques that we can use. And I think it's a mark of the experienced clinician that we might graduate from acupuncture school as kind of one-trick ponies. We've got some particular technique, some particular teacher that we followed, and we like to apply that to everyone because that's our comfort zone, and that's what we really struggled to master in our beginning practice. But with time, we start to find that any one technique is limited in its application. Certain patients don't respond, certain conditions don't resolve very effectively with it, and we have to branch out and have a larger toolbox to be able to treat a wider variety of patients and their conditions. So here's my toolbox that I'm sharing with you. So any pain at all, we can, but particularly in the absence of any physical exam findings, we can't really find anything abnormal on physical exam, but the patient has significant pain. This is where I use both electroacupuncture and non-local acupuncture or distant acupuncture. Distant acupuncture I already talked about. We're going to talk a little bit about electroacupuncture later. You'll see these blue text links to specialty courses on my website that are specific to this technique where we go into much more depth. This is really a survey class here. So if you want to know more about electroacupuncture, I've got a 3-hour class devoted specifically to electroacupuncture. If on inspection and palpation we see signs of blood stasis, venous engorgement, spider nevi, darkened areas, 7-star lancet and 3-edge needling, and also euphemistically called wet cupping, applying a suction cup over an area after we've used a 7-star lancet or a 3-edge needle to draw out congested blood and fluid. If on palpation we find gritty, localized adhesions, a lot of taut, tender fibrous bands with tender trigger points in them, this is where myofascial trigger point needling excels. Myofascial gua sha, very useful. Electroacupuncture can also be helpful, but really the primary modalities that I find most effective are trigger point needling and myofascial gua sha. If we instead have kind of smooth muscular atrophy or a very hyper or hypotonic muscle, but it's relatively uniform in its consistency, motor zone needling, electroacupuncture needling can be helpful to normalize neuromuscular function there. Specialty physical exam techniques that I teach in person in my in-person classes, joint range of motion assessment and joint play or end field testing. If we find joint hyper or hypomobility or joint dysfunctions in how the joint moves, joint and ligament needling. Myofascial pain it seems to be limiting joint range of motion. The muscle is too tight to allow the joint to move fully. Again, trigger or motor zone needling, gua sha, and cupping, all useful. If we perform manual strength testing, we find that there's neuropathic weakness, meaning the tissue is not getting enough nerve signaling to contract effectively. Electroacupuncture, motor zone or motor point needling can be helpful. If it's more pain rather than nerve damage that's inhibiting the function, tendinomuscular pain, we can treat again with myofascial trigger point needling or gua sha. So this is my way that I offer up of matching your physical exam findings in terms of inspection and palpation, or contemporary methods like joint range of motion measurement, joint play and field testing, manual strength testing. All of these can lead very specifically to pulling particular tools out of our toolbox to apply to local problems. So any questions here before I move on to our next slide? Okay, so I'm going to talk now about myofascial trigger point needling in a little more depth. This technique, I certainly see a description of something that's very, very similar to contemporary, dry or myofascial trigger point needling in the Neijing Ling Shu chapter 13. Apply rapid insertion and withdrawal of the heated needle and cease when the puncturing begins to affect the cure, irrespective of the period of treatment. Insert needles into tender spots in the diseased area. So I'm thanking David Legge for translating this section of the Neijing Ling Shu in his specialty text, the Jingjin Acupuncture Treatment of the Muscular System using the Meridian Sinews, a book that he published in 2010, specifically translating this section of the Neijing. A little note, heated needle refers to, I think, putting a needle in a candle flame. That's something we aren't trained to do in the West, cauterized tissue. So I would kind of leave that out. But otherwise, this is a fairly consistent description with contemporary myofascial trigger point needling. We insert and partially withdraw the needle into trigger points, into tender areas. And once it begins to affect the cure, we don't need to retain the needle and leave it in there. We might reduce the trigger point in as little as 30 seconds or a minute, or sometimes I've taken as much as 45 minutes with a really large stubborn trigger point. But it's a different technique than put the needle in and just sort of let it sit there. Okay. So I want to illustrate here a little bit how the difference between the classical Jingjin approach versus contemporary TCM, just using dorsolateral elbow pain or tennis elbow pain as an example. So contemporary TCM text or training tells us to use a mix of local points such as large intestine 10, 11, and 12, or the extra point Chu Yang Wei, outer elbow Yang, adjacent points like triple warmer 8, 9, and 10, distal points like large intestine 4 and 5, and also treat any associated disharmonies of the internal organs, or the 4 substances or the 8 patterns, the Bagong, the Zongfu, Xieqi, external evils, etc. So treat the whole picture. Nothing wrong with that, but it doesn't do a whole lot to treat the local problem very effectively, unless you needle into tender locations along the arm, Yang Ming and Shaoyang. And that's the classical description of how to treat this. Is not rebalancing the whole body and hoping that has an effect on the elbow. It's to treat the elbow. So I'm going to look at a couple muscles in a moment to talk about in more detail, but this is a relatively easy technique to learn for those of us that are already trained to palpate for and find acupuncture points. We don't have to memorize any new point locations or indications. We can integrate this with any other acupuncture technique or modality, and there's no special devices, no special needles required. You can combine it with other therapies in the same visit. You don't need any new diagnostic paradigms or physical exam skills, except for it helps to really know your muscle anatomy very well. And there are some specialized palpatory skills, really developing sensitivity to myofascial adhesions and trigger points. There's a few muscles that needling into does require some additional safety training beyond what's typically taught at the master's level in the West, to avoid arterial or organ puncture, but not that many muscles, and in practice it's actually quite easy in general to avoid any critical structures. So here's a couple of muscles that we'll look at. This is one of the muscles that will generate pain along the dorsolateral elbow, referring to the kind of the lateral epicondyle area. there may be no trouble at the lateral epicondyle itself. Instead, what we have is a trigger point in the extensor digitorum superficialis muscle. Now, there's a half dozen muscles or so, all of which can contribute to and involved in tennis elbow. So this is not the only one. I'm just using this particular one to illustrate a couple of things. Functionally and structurally, this muscle is clearly, according to basically all translators, is a Shaoyang Jingjin muscle, triple warmer, okay? But look at the referred pain pattern. It follows fascicles, specific bundles that turn into tendon slips that go to all the fingers except for the thumb. And the referred pain pattern typically goes to a couple locations where, in theory, there are no classical Jingluo points. The middle finger, the back of the middle finger, and the back of the ring finger. Okay, so I'm using this muscle to illustrate the limitations of sticking to the classical acupuncture locations, the Jingluo, and ignoring the Jingjin. You may miss a clinically significant muscle here that is a major pain generator for tennis elbow and also for pain radiating along the dorsum of the forearm and the wrist and the hand. Okay, the technique we can use to get into the trigger points here, because it is a superficial muscle just beneath the surface of the skin, is needling superficially. And by needling kind of perpendicular to the muscle fiber orientation across the grain of the muscle, we're more likely to pick up a trigger point and reduce it than if we try to go vertical and puncture through instead of a classical, approach of I shouldn't say classical, it's actually a modern TCM approach of just every needle gets inserted perpendicularly. That doesn't work very well for the Jingjin. We have to think about three-dimensional structure and function of the muscle and how we can best reduce trigger points and find them, depending on where they are. Some muscles are very deep or thick, but this is a superficial one. So, okay. Here's another muscle that might not ever come to our attention if we're thinking in strict Jingluo meridian terms, because the supinator is a curious muscle. Functionally, it's clearly an arm tie-in Jingjing muscle. It supinates the forearm, which is a tie-in function. But structurally, it crosses from the tie-in zone in the cubital fossa, wraps around the back of the radius and inserts into the ulna, into the dorsum of the proximal ulna. It also attaches to the radiocollateral annular ligaments. It's a complex muscle. And so it kind of spans the lateral proximal radius, which we might consider a tie-in zone, goes around the back of the arm, crossing over all the yang Jingjin. Okay, and the position in which we put the elbow and the forearm in order to needle it makes a difference. So the forearm supinated, we can kind of needle to the bone, but in the cubital fossa around lung 5, roughly, into a trigger point that we might find by palpation. But we have to aim that needle laterally towards the lateral epicondyle in order to avoid the median nerve and the radial artery. But we can also affect treatment by withdrawing that needle and pronating the forearm and inserting along the proximal dorsal ulnar border towards the lateral cubital fossa, getting into those attachments, the yang aspect of the supinator muscle where it attaches to the ulna. Okay, so those are the two muscles I just want to use as an example of how thinking in three-dimensional terms about the Jingjin and the structure of the muscle and how to safely and effectively reduce trigger points in it will get us a lot more than following the TCM method of just simply needling Jingluo locations, local and adjacent and distant. Okay, so any questions about that? Okay, moving on then. So locating myofascial trigger points or Usher points is actually really more important than the needle technique itself. Needle technique is pretty simple. You just insert the needle into the trigger point and probe around. But if you don't spend time up front really carefully locating key trigger points, Usher points, you can waste a lot of time fishing around through essentially healthy or minimally disturbed tissue with a needle trying to find the trigger point. So here are the sort of steps involved. First, palpating for a taut fibrous band. I'm actually going to stop screen share for just a moment. I'll go back to the slideshow, but I want to illustrate what I'm talking about. So say that extensor digitorum superficialis muscle that I want to treat, running my fingers perpendicularly across the muscle fiber orientation will allow me to find the most taut and tender band or fascicle within that muscle. And I can find one pretty quickly here in my own forearm. I've had trouble with tennis elbow in this left arm periodically. And there's still one band, although I've treated it sometimes myself. Here's a band that currently, when I run my fingers over it, it's more resistant, and you can kind of see it twanging underneath the surface of my skin like a guitar string or a chord or something. And whereas a tissue that doesn't have that, you don't see as much of a longitudinal disturbance of the muscle when I run my finger across it, okay? And when I find that particularly tender band, I can feel it radiating down to my ring finger. That's the fascicle of the extensor digitorum superficialis muscle that the tendon supplies my ring finger, okay? So that's where I would want to needle into. I'm going to go back to my slideshow now. So that's one technique, is that superficial cross fiber strumming, or also pinching, plucking the skin and muscle away from the underlying tissue. And sometimes we can find it by rolling it between our fingers, like we see in the column on the right-hand side here. We can also probe more deeply. Muscles like the gluteals or the quadriceps can have very deep trigger points. The hamstrings, big, powerful muscles like the deltoids and so on. We may have to probe deeply to find tender trigger points. And then feeling for, again, tissue abnormalities, just like we're told by the Neijing: grainy, rough, hard, thicker, resistant to movement. But I also want to be looking at my patient's face while I do this, looking for any reflexive wincing or flinching or jumping, grimacing. This is much more reliable than a verbal report, as all the subconscious reflexive responses to tenderness. But I do rely also on the verbal part. If they say, that's the spot, that's the pain I've been feeling, that symptom reproduction tells me I'm on a very clinically significant trigger point that needs to be needled. And finally, referred pain, pain traveling typically proximally or distally along a limb, or sometimes crossways across a limb. And then really trying to finally visualize this trigger point in 3 dimensions, not 2-dimensional maps, but 3-dimensional understanding. You know, how deep is it? You know, where is it located within the muscle belly? Okay. So I know when I'm in the bullseye in the target zone with a needle is that I reproduce the patient's typical symptoms, the pain they've been feeling. But twitch responses that are reflexes provoked by needling into a trigger point, and also provocation of referred pain, also are pretty darn close to the bullseye. They're also very clinically significant. I will settle for significant tenderness, meaning grade 2 means unconscious or reflexive facial wincing or grimacing. But if I only have really insignificant tenderness, grade 1 or less, no tenderness, no twitch response, no symptom reproduction, no referred pain, I've really missed the target. And I just need to withdraw the needle and reevaluate, palpate, start again, okay? The technique, after penetration of the skin, probing around, asking the patient about tenderness or soreness, watching their facial expressions again for anything that looks like a reflexive grimacing, wincing, etc. Reproduction of referred pain, feeling with the needle tip, paying attention to how the tissue feels at the tip of the needle, and looking for resistance, areas of density, fibrous bands that twitch, gritty, sticky, gummy, or even crunchy areas that can feel like old glue or styrofoam. Very bizarre feeling. A healthy muscle is not tender to needle insertion and feels like you're needling into molasses or butter. Smooth, uniform, soft, supple. So by paying attention, and I do recommend trying this on yourself, you'll feel at both ends of the needle very effectively. It's a great way to learn. Pay attention to how the needle tip feels. You're more likely to get into the heart of the trigger point, which is an area of contracture that where there's no electrical activity taking place. The muscles become kind of inert and stagnant here, and there are compressed capillary beds, typically upstream, where the blood is not flowing until you break up the trigger point with the needle, relax it by provoking those twitch responses, and And we want to continue probing until the referred pain goes away, the twitch responses subside or reduced to negligible, or the patient's limits of tolerance are reached. So I can hear, without any of you unmuting, probably many of you asking yourself, do I want to use this technique? He keeps talking about wincing and grimacing and reproducing patient's typical symptoms. So this is a conversation with the patient. It's very important to begin with to educate the patient in advance. This is going to feel very different than needling using thin gauge sarin needles into non-tender locations, distant, far away from the site of the pain. And if that's all your patient is used to, it's very important to educate them up front. This is going to be kind of hurts good pain, like a deep tissue massage or a strong workout where you're really challenging a muscle that is weak, sore, and pain inhibited by making it contract, making it fire or jump by needling into the trigger points. Sometimes these are quite strong. And maybe even producing a whole body jump more than just a local twitch. But this is described classically as the fish biting the hook sensation. And what we don't want to mistake it for, though, is nerve trauma. So nerve trauma is very, very different. Nerve trauma is not hurts good, it's hurts bad. It's a sharp tingling electrical shock radiating to the fingers or the toes, okay? And that's not something that I intend to do with this technique. It actually can be therapeutic for nerve injuries, but that's a different class. For myofascial trigger point needling, I'm not trying to target nerves, I'm trying to avoid them while getting into the trigger points. And the experience of myself and many other clinicians that use this technique is that the patient understands in advance and has consented to a different style of needling, they actually will tolerate an awful lot, particularly when they feel the results. I wouldn't use this technique if I hadn't discovered through my own experience that it can produce very, very long-lasting, significant reduction in pain and improvement in muscle function. And by long-lasting, I'm talking weeks and months out of a single session, sometimes indefinitely. And with multiple sessions, not that many, but maybe a half dozen or so, we may sort of permanently reduce trigger points and restore pain-free muscle functioning. Okay, so it's a very useful technique. It's just a matter of getting your patient to understand that it's going to be useful, and there's nothing like results to get a patient on board. Okay. So these twitch responses can also happen with other forms of acupuncture. And before I understood that these were reflexes that were fired by the body when you needle into a trigger point, I would apologize to the patient if I caused a twitch response. I would be afraid that I'd injured them. They would be afraid that I'd injured them, et cetera. And I lost a few patients that way that now I can retain by having this conversation in advance about twitch responses and how therapeutic they are. And then the patient embraces it rather than flees from it. Okay. Now, there's some controversy among practitioners about whether the twitch responses are essential, but there seems to be a fairly broad consensus that the outcomes are improved if the twitch responses are elicited until they cease, and that way the trigger point is effectively reduced and you have longer lasting benefit. But that is something of a personal choice. There are practitioners who teach a style you try to reduce the trigger point without producing a whole lot of twitching, and there's people who go at it very, very aggressively. I try to match the strength of my technique to the patient's tolerance and the patient's goals. The patient who comes in and says, I'm already in pain and I've got a triathlon's coming up in a month and I just want to get over the pain and be in good shape for it. Do whatever you need to do, doc. Or sometimes my patient is another acupuncturist who trusts the process and says the same thing. Okay, we'll go for it. We'll reduce that trigger point to nothing, even if it's a lot of strong, painful contractions and you have a lot of post-needling soreness. The next patient comes in and says, I'm in so much pain. I really don't want to experience any more pain. Okay, we might not even use this technique. We'll start with distant acupuncture, ear, scalp, et cetera, maybe some electrical stimulation. And if that doesn't produce the desired results, they may be more open to trying some local needling, but I will still go slow, gentle, maybe 1 or 2 twitches is enough for any given session until they start to embrace the process. And that's certainly a possibility. I've taken patients who, I only want pediatric serums and nothing local to, can you get into that trigger point again? It hurt, but it felt so good when it was, last time, and just maybe we can get rid of it all the way this time, okay? So here are the muscles that I would recommend that rather than do it yourself, based on my class today, that you seek out some specialty training, some hands-on training first. I won't go through each muscle in detail now. I'm just saying, look this over. These can be very clinically significant muscles, very, very useful to needle into, but it's important to just know how to avoid critical structures in these muscles. But you can obviously continue to use your classical acupuncture locations and their angles and depths, okay? There's a few muscles where there's not so much a safety consideration. It's just that very powerful muscles like the gastroc, the quadriceps, and the hamstrings, when they fire very strongly. Big, powerful twitch responses. I would not use a thin gauge needle. I use a minimum 30 gauge, often 28 gauge needle here. I don't want needles getting bent or worst case scenario, broken by a very strong twitch response. 1 or 2 twitches enough for any given session. I don't treat both legs at the same time. I want the patient to be able to walk out with at least one leg that doesn't have any post-needling soreness. Sternocleidomastoid, masseter, quadriceps, the post-needling soreness can be very strong and can last for several days afterwards. So these are muscles where I'm just cautious in terms of how much I attempt on any given visit. But here are some muscles that are really good risk to benefit ratios, good discomfort to benefit ratios. These are good ones to start with. And I've highlighted in green muscles that very frequently develop significant trigger points. And these are some very useful muscles to know how to treat: the supraspinatus, the infraspinatus, teres minor, and the rotator cuff, the forearm extensor muscles like extensor digitorum superficialis, extensor carpi radialis longus, all those extensor muscles in the forearm, the gluteals, quads, hamstrings, tensor fasciolata, tibialis anterior, the peroneals, etc. Okay, so these are places that I would suggest starting with. Okay. Now, unless anyone has any specific questions about myofascial trigger point needling, I'm going to move on to talking about joint and ligament needling. Okay, so joint and ligament needling, technique that I use most frequently, and is probably the least taught, least practiced, least understood technique of these orthopedic acupuncture techniques. And I don't know why, because it's very effective. It's more comfortable than trigger point needling, and produces very long-lasting results. And in general, there are actually fewer safety issues because joints do not have internal organs. They don't have blood vessels. They don't have neural structures. They're largely inert tissue and very safe to needle into. But they're very clinically significant. And here's my example: a torn anterior cruciate ligament in the knee. Ligamentous and capsular tissues of joints do not heal well. They heal incompletely, if at all, because they've got very poor blood supply. And once sprained, stretched out, deformed, damaged, they tend to stay that way. The joint is hypermobile, but eventually starts to become hypomobile as the loss of stability and function of the joint causes abnormal contact between the hyaline cartilage end plates and wears them out prematurely, and you start developing bone spurring and roughening of the bony surfaces, and eventually osteoarthrosis, joint degeneration, and and loss of range of motion, stiffness, and pain, etc. We also get compensatory overloading of the muscles and tendons and other joints along the pathway. So, for example, an arthritic knee joint, the patients will typically start to develop problems in their quadriceps, their hamstrings, their gastrocnemius. The muscles that cross the knee joint become overworked or dysfunctionally worked because of the loss of joint structure and function. They start to develop the myofascial strains and trigger points that we just talked about, tendon problems, bursitis, and compression neuropathies. What we can do is needle into tight structures at the hypomobile aspects if the joint is stiff, breaking up scarring and adhesions in the ligaments and capsule, increasing blood flow and tissue repair, reducing inflammation, and restoring joint mobility, and also needling into lax structures at the hypermobile aspects of the joint. So a common imbalance or pattern in the knee that we start to see: the medial knee is most vulnerable to sprains. The medial collateral ligament, the anterior cruciate ligament, can get disrupted, the medial meniscus. That part of the joint becomes hypermobile, too wobbly, inflamed, often with swelling. And needling into it will produce an immediate reflexive response where the ligament tightens up, shortens, contracts therapeutically to stabilize the medial knee. And the increased blood flow and the release of tissue growth factors will cause those ligaments and that part of the joint capsule or meniscus to bulk up, to hypertrophy and lay down collagen fibers. And over about 6 months or so, becomes progressively stronger out of a single needling treatment. And with a little repetition, sometimes, that may last really indefinitely, where that knee that was once wobbly and hypermobile is stabilized. Meanwhile, on the outside of the knee, to compensate for the weakness of the medial knee, we have tightening of structures that we can then loosen up by needling directly into them, such as the lateral collateral ligament. Okay. And all the secondary problems that develop from joint dysfunctions, muscle pain, tendon problems, joint nerve problems, et cetera, will heal a lot better when the joint mobility and stability are restored. This is true orthopedic acupuncture, treating the most critical, deepest structure in the body. And if we fail to restabilize a joint and improve its functioning and tracking, everything else doesn't work as well and tends to come back. With a stable joint, everything will work better and the results will be longer lasting. Okay. So this too can be easily integrated with other needling techniques. The same visit, it's actually very fast, very rapid to apply. Typically, often less than a minute or within a few minutes. Then there is no need to retain the needle. It doesn't do anything additional to retain the needle. Little repetition is needed. Typically 1 to 4 visits is sufficient. If I get to 6 visits and the joint keeps slipping back into dysfunction and hypermobility, the technique's not working. That occasionally happens, and not very common, but if it does, that tells me that there's something significantly disrupted in the joint tissue that may be beyond what needling can do, or at least dry needling. I will refer them on for proliferative therapy, regenerative injection therapy, or maybe surgery. And if we follow clean needle technique, that's really the only thing, is making sure your needle is really clean. It's got a very good risk to benefit ratio. And the one thing here is that this does require some additional physical exam skills. Now, one of them is pretty simple. It's simply palpating for tenderness along the joint line, but that means you really have to know your anatomy, because the joint line can sometimes be fairly subtle and not so easy to find. The tibiofemoral joint line in the knee is one of the easiest, but some of the other very small joints or joint lines that are embedded in fairly deeply into tissue can be a little harder to locate. And if we learn an additional manual joint play testing technique, we can verify immediately upon withdrawing the needle. We can retest the joint and it should be firm and stable where it was previously loose and wobbly. So that's an easily learned technique, much easier than pulse, but it does take a little hands-on training to know how to do it and what you're feeling for. But put those together, you can identify you can identify a hypermobile joint that's lax and wobbly, find the tender location in the ligaments and capsule, needle into them, pull the needle out, or recheck the joint, and the vast majority of the time it's restabilized, and the patient can feel the difference. They put weight on it, they use it, and instead of being painful and wobbly, it feels strong, pain-free, and stable. Okay. So the main safety issue here in general is just simply that large joints like the knee, shoulder, and hip can become septic if we use a dirty needle. So this is where it's really important to scrupulously practice clean needle technique. And I exceed the standards of clean needle technique manual that we use in the US for safety by using either betadine or iodine or chlorhexidine to sterilize the skin, not just rubbing alcohol to clean it. Okay. This reduces the risk to negligible of any kind of joint infection or sepsis. Also, there's some joints, even though they don't themselves have any critical structures inside them, they lie very near some critical structures. And here's my list of ones to seek out hands-on training first before you needle into the anterior hip joint, for example, or the sternoclavicular joint. Okay. And this is what I teach, of course, in in-person classes. Okay. So for developing skill in this technique, here are some resources. It really helps to study 3D anatomy, joint biomechanics, kinesiology, the science of movement. Cadaver lab skeletons and joint models are the best, but good quality medical student level textbooks or online anatomy apps are supplementary but very useful. Undergrad level medical texts often neglect ligaments. Ligaments are a kind of a forgotten, neglected tissue, even though they're critical for orthopedics. So you have to seek out a medical student level anatomy reference for this. And practice on yourself or practice on your patients or your colleagues, joint line palpation, joint plane infield testing. Add this to your routine physical exam procedures, and starting with frequently injured, clinically significant joints. They're easy to find. A acromioclavicular joint is a great example where the collarbone inserts into the scapula. Okay. Okay. So I'm going to skip through these. These are reference slides. I'm giving you some target and some. These are joints I would recommend for developing this technique. They're commonly injured joints, very safe, no major safety issues. They're easy to treat. They respond well. Okay, so here's the upper limb, here's the lower limb, there's the axial body. Okay. Now, with both of these techniques, there can be some discomfort during needling, fairly commonly. And again, if we have we do our informed consent and educate the patient in advance and they agree to it, if we maintain an open, non-defensive line of communication with them, they know that they can tell us to stop or that they need a break at any time. Usually it just goes fine. And short breaks do allow the patient to relax and integrate the sensation. And I'm talking by short, I mean, less than 5 minutes. It's typically enough for any joint or muscle soreness from needling to subside, and then you can resume needling if needed. Sometimes you don't need to resume needling. You can feel the tissue change right away. You can withdraw the needle. The joint needling, like I say, works faster than the trigger point needling. Typically, if I withdraw a needle and recheck it, the joint is restabilized. Sometimes myofascial trigger points require longer needling. Okay. During that time, we can do other things. We can do additional needling elsewhere. We can use suction cups or gua sha, or we can put in our ear, our scalp, our distal needles. We can chit chat about the weather. We can do our charting. Distraction sometimes helps, rather than just letting the patient sit there in silence and focus on the needle. Encourage them to breathe deeply. We can talk to them, etc. And then in a few minutes, the needle it's comfortable enough. We can resume needling. Okay. We can also retain those needles and use electroacupuncture, which is what I'm going to talk about next. And we can apply a hot pack or do some massage in the area after we take the needle out if it's still really sore or tender. Okay. So here are some techniques we can advise the patient to do on their own to manage any post-needling soreness. Massage, self-massage, topical moist heat, such as a warm bath, hot shower, hot water bottle wrapped in a wet towel, a balance between relative rest and light exercise, and know that it'll go away. Typically, it will go away somewhere between the same day or maybe up to 3 days or so. And typically, the muscle pain feels a little bit like delayed onset muscle soreness from a workout. It's essentially that's what's happened, is you've made a particular bundle in the muscle tissue really work hard. Okay. Again, I really encourage to practice on yourself if you wanted to try any of these techniques. Again, I do, of course, this is the focus of my in-person training, but if you want to get started by needling, the forearm is a perfect place, the dorsal forearm, elbow, and wrist. Safe, easy, often symptomatic, particularly those of us that spend any time on computers or doing massage. Just pull out your anatomy reference, think about what you're feeling, what you're needling into, and being able to tell the patient, I know what this feels like. I've done it to myself. I've had it done to me. This facilitates patient trust and acceptance greatly. I never want to apply to a patient a technique that I haven't undergone myself. I want to be able to look them in the eye and say, I've had this done to me. I've done it to myself. I know what it feels like. So I said I'd talk about electroacupuncture next. Here are what I see as the clinical indications where electroacupuncture has a particularly favorable risk plus discomfort to benefit ratio, where the benefit outweighs any risk or discomfort. And actually, electroacupuncture is generally very well tolerated by most patients. I find more comfortable than strong manual needling. But here's when I really reach for my electrical stim device. Neuropathic pain, where the damaged nerve is the pain generator. not just a pain messenger, such as carpal tunnel syndrome, spinal nerve root pain, or inflammation, sciatica, or a neuropathy, a more serious damage to the nerve, where we have an actual sensory motor deficit or muscle atrophy due to nerve damage, not just pain, but loss of function in the muscle and in sensation. Electroacupuncture device. That's when I pull it out. Muscular atrophy or hypofunction from pain-inhibited disuse. There's no actual damage to the nerve, but the patient has really stopped using the muscle because the pain is so severe. I reach for my electrical stim device. Where tissue repair is really paramount importance, things like fracture unionization, wound healing, acute joint sprains, and muscle strains. Here we want to keep the amplitude of the electrical stim device fairly low, below the level that causes muscle contractions, but electrical stim speeds up cell metabolism, which means speeds up tissue repair. Sometimes a patient who just does not tolerate, even with informed consent, even with self-management techniques, even with an open line of communication, there are some patients like, the trigger point needling, the joint needling is too painful for me. I reach for my electrical stimulator. We're going to quiet down and calm down and normalize the function of hypersensitive nerves in the area. And after a few sessions of electroacupuncture, those nerves may be reset to more normal functioning, and then the patient will be able to tolerate stronger needling techniques locally. Really, any severe disabling pain that's interfering with sleep, affecting mood and daily function, I use my electrical stimulator. And you can combine it with any other form of therapy. There's very few cautions and contraindications that I'm going to list here in a moment, but I'll say overall, this is a often maligned and feared technique that is actually safer. That all the dangers associated with electroacupuncture come from the needles, not from the electrical stimulation. So here's some of the advantages is that particularly for the patient who has a lot of issues around control, or the patient is hypersensitive to needling, it can provide a very safe and steady stimulation without my personal attendance. And I can actually put the controls where the patient can dial up or down the level of electrical stimulation themselves. And these devices are very safe. They won't injure themselves by doing something wrong. The most that can happen is they turn it up to a point where it's uncomfortable for them, and they just turn it back down. Safer than needling, safer than herbs, safer than manual exercise therapies. It's a great place to start if you're a beginning practitioner and still developing your skill set. My first few years, I used electroacupuncture a lot. Don't use it quite as often anymore. I'm more selective in my choice, but it's so easy and safe to apply. And if nothing else, you can connect electrodes to classical acupuncture locations or shear points. And often that will work fairly well by itself to treat pain and disability, as long as there's not too much structural damage. So I think in view of time, I'm going to kind of skip over this. You can look at this reference slide on your own about the physiologic effects of electroacupuncture. What I want to talk about is the clinical applications. Actually, I really talked about all of this. So I'm going to skip over this slide as well. I've mentioned all this. You can use it with any other modality. I usually use electroacupuncture after any uncomfortable therapies. I want to end with something that is actually comfortable and well tolerated, and really it's designed to reduce pain. So I might do my strong Twee-Nog, Gua-Sha, cupping, manual needling first, and then finish with hooking up the electrical stim to any retained needles. Okay, but it can also be a standalone treatment. So, for example, carpal tunnel syndrome. We're doing two things here. We want to block pain signals from making their way from the wrist. Electrical stimulation will both block pain signals at the wrist where the pain is originating, and also at the level of the spinal cord where those nerves enter the spine and enter the cord and head on up to the brain. Simultaneously, we want to stimulate nerve repair and nerve function by needling locally along the course of the nerve and hooking up the electrical stim device. Now, one thing you do not have to worry about with this is, which do I connect the red lead or the black lead, or the green wire and the blue wire, and yin yang, up down, left right, negative positive. None of that makes any difference at all, because all modern electroacupuncture devices are default set to mixed alternating current. So the polarity is going to reverse with every single pulse, and it does not matter What matters, all the coloration of the lead, the polarity issues, et cetera, it's reverses every single pulse. What does matter is hooking up the key needles in a pattern, something like this that I'm showing here. The blockade at the spine, the blockade at the site of origin, and then along the pathway of the nerve. Okay. And I know that may be controversial, may be different than something you've heard elsewhere, but I will stand by that. And anyone's free to email me their questions afterwards. So same thing here for sciatica or lumbar nerve root entrapment or radiculopathy. Blockade at the level of the spine, blockade at where the sciatic nerve is getting entrapped by the piriformis or the gluteal muscles, and then stimulation along the nerve pathway where the sciatic nerve supplies the back of the leg. Okay. So any questions about that, about the use of electroacupuncture? Okay, again, this is a survey class, not intended as a complete class, but it's to, hopefully you'll come out of this going, oh, here's a technique that I have underused or not used enough. I'm going to talk about one last cluster of needling techniques, and then we'll be pretty close to our end time here. Three-edged lancet and seven-star needles. So three-edged and lancet needles have a cutting edge, right? A blade that makes them more useful for aspirating engorged blood in a spider nevi or something that looks like this, regions of capillary stasis. But it also means they can cut nerves and tendons. So we have to be more careful how we wield them to know our subsurface anatomy so we don't end up cutting any critical structures. Okay. This is not my main technique. It's not, but when I do see engorged veins, spider nevi, or other regions of capillary stasis along the affected Jing-Jin that I'm trying to treat, I definitely will use this technique because it can be very effective. And this one I cannot explain very well in contemporary orthopedic or vascular terms how it works. I can just say that it does work just the way the Chinese classics say it should. Okay, we don't typically retain the needles at all. We just poke in and out. The quantity of blood is very, very little, typically much less than people donate for a blood draw or women lose through menstruation. And we can easily control the quantity of blood that comes out unless we have a hemophiliac patient or a patient on prescription strength blood thinners, and both of those would be contraindications or at least extreme cautions to using these techniques. Okay. So we don't use it on varicose veins like we do on the right. We instead use it on engorged non-varicose veins, such as we see on the left here. Okay. The traditional indications being heat and blood stasis along ipsilaterally. Okay. Electroacupuncture, distant acupuncture, a lot of that will cross over the spinal cord to the other side of the body. We often needle bilaterally, or we can affect the opposite side through needling. These techniques addressing vascular and lymphatic congestion are really ipsilateral. They only really have effects on the same side of the body, and that has to do with the organization of the vascular and lymphatic systems, which are sort of drain ipsilaterally one-sided into the venous return system and the vena cava, versus the nervous system that has crossover to the other side of the body. Okay, so. I think I really talked about all this. So opinions vary as to how much blood needs to be released to have a good effect. My experience generally is the more that comes out, the more effective the technique is. But Master Dong style acupuncture, they're just looking for a single drop of blood. Miriam Lee style acupuncture, they'd be happy if they get a cup or two. Okay. Now, of course, with large quantities, we really need to monitor our patient for any dizziness, faintness, or anything like that. And if we see that, we really have done too much. I've never actually had that happen with using these needles, but that's something we should keep an eye out for. If we're having trouble getting any blood out, and we feel like we need to get more, it's one thing we can do is just swab the puncture area with isopropyl rubbing alcohol that reduces blood clotting, or we can apply a suction cup over the place where we've needled. Okay. What kind of blood? Where we see the greatest treatment effects is from kind of something that looks like a dark red or almost black slug of viscous clotted blood comes out. Fresh, smooth flowing red blood, we're not as likely to get a significant response. If we get kind of a yellow exudate, it's probably lymph fluid. That's not very, I don't see that very often, but usually that also goes along with good treatment effects. Okay. Now, one thing that has to be said about three-edge needles, in addition to knowing your surface, your anatomy, and avoiding tendons and nerves or any kind of certainly internal organs too, is that that the needle does not have a stop. Lancets do have a stop, so they are safer. Three-edge needles, we have to be sure we really have a very secure grip on the needle because it doesn't have a handle or a stop, and it could actually slide into the body, which would be something, of course, we don't want to see. Okay. 7-star and plum blossom needling doesn't have that problem because we have the large stop here and they're very short needles. And this is for, instead of treating a specific engorged vein or spider by treating a large area, we should sterilize the skin, in my view, with chlorhexidine or iodine to be safe, because we're repeatedly puncturing it with the same needle. Okay. And the applications here, in addition to large diffuse areas of capillary stagnation, any non-infectious inflammation, swelling, redness, as long as we know that's not an underlying infection. Particularly, I've used this most often for acute disc injuries, capsulitis, or bursitis. Okay. The other thing we need to do with 7-star needling is apply a bandage over the skin. This is not required by clean needle technique, but it should be. Sterile gauze, it should be kept in place for about 3 days or so afterwards, and the patient should be advised to stay out of public swimming pools, lakes, rivers, hot tubs, etc., where they could get a skin infection. Okay, practice good skin hygiene. Okay. So we are about out of time here. I'm just going to mention very briefly my last couple of slides. These are flow charts that you can look at in your own time about the indications for gua sha, myofascial gua sha, and cupping techniques. What I'll say about them is that they are different than what we might call wei qi cupping and wei qi gua sha, which are relatively light pressure or negative pressure in the case of cups, are relatively superficial. Often we can get a better effect by using a gua sha tool to kind of dig more deeply into deeper areas of adhesion in a muscle, or applying really strong suction cupping and having the patient move their body around that limb region. For example, their paraspinal muscles, putting cups on there and then having the patient move their body, their spine, do cat and cow from yoga, flex, extend, side bend, rotate, etc. at the same time, works better than static cupping. And thank you very much for your time and your attention. And that concludes the content of today's webinar.